All right, great.
Thank you. Sir, shall we start the case presentation, sir?
1 second. We will let you know. First, there will be introduction.
Just a minute, sir. Manoj, sir, you can start.
Manoj, yeah.
Sure, sir. Good evening, ladies and gentlemen. Welcome to episode 34th. And this time we have interesting case presentation from Department of Neurology, Government Mohan Kumar Mangalam Medical College, Salem, Tamil Nadu. Welcome to the longest running web series in the field of neurology and probably at a global platform as well. Warm welcome to our presenters and and there will be a concluding remarks as well. We would also like to warmly welcome our course directors because of their untiring effort. This longest running web series in the field of neurology is happening at a global platform, and we would intend to conclude it by 9:30. We need no introduction. The gentleman on the screen, Professor Dr. Sudhir Vaishya, Professor and Head Department, NHL, MMC and SBPI MSR, Ahmedabad. Sir is also Director of Neuroscience at prestigious Sterling Hospital, Ahmedabad. Many accolades to Sir's credit, but just to mention a few, because of his untiring work to society and clinical research, Sir was conferred with most prestigious Padam Shri.
Thank you.
And Sir is also a recipient of BC Roy Award and many accolades, and Sir's interest is stroke, neurodegenerative disease, and epilepsy. Our second program director, equally accoladable, Professor Dr. Lakshmi Narasimhan Ranganathan, Sir, Director and Professor, Institute of Neurology at Madras Medical College, Chennai, the same place from where he was a student, is now heading the department. Many awards and accolades to Sir's credit as well. L2C Advisor from Oman, A.B. Baker's Award for Global Best Teacher, Best Paper Award, and Sir's contribution also to academics has been extremely praiseworthy. It's our honor and privilege to welcome our program director, Professor Dr. Sudhir Sir and Dr. Lakshmi Narasimhan Sir. May I request you to kindly take it forward and start the proceedings, sir.
Thank you. Thank you, Dr. Manoj Kumar. And it has been a wonderful journey all throughout these 34 months. Thanks to the untiring efforts of all the presenters from different medical colleges across the whole India, and the wonderful deliberation, superb cases, and high-level discussions, which has kept up the whole interest alive. And that's the reason why this is one of the most popular and longest running web series of neurology learning. As you know, Secrets of Neurology was originally meant for DM and DNB neurology candidates, but it is so popular that many people from professorial rank as well as practicing neurologists also join, and there are people who join all across the globe from different countries also. So I thank all the delegates for their continuous support, encouragement, and feedback. May I have the next slide, please? The next one, yeah. So today we have Government Mohan Kumar Mangalam Medical College, Salem from Tamil Nadu, who has accepted the invitation, and I thank Professor C. Kumar and the team for being here to impart knowledge and discussion with all of us. So it will go like this. Dr. Divya Sevaraj, the DM resident from the same department, would start the case presentation, followed by next one. Dr. Bala Pradeep Boidapu, who is another DM resident from the same department, Government Medical College, Salem TN, would take discussion further. And thanks to Dr. S. Shiv Kumar, the professor and HOD, Department of Neurology, Government Medical College, Salem TN, Salem, Tamil Nadu, who will give the expert remarks and a lot of knowledge imparted to us. As you know, Dr. Shiv Kumar S is MBBS from Stanley Medical College, 1988. He was MD in General Medicine from Mysore Medical College in 1993. And then he secured his DM Neurology degree from Madras Medical Institute of Neurology in 1997. So you can understand he has a 25 years of standing in the field of neurology, clinical neurology. And he is also a member of IAN, IMA, API, and so many other bodies. So once again, I want to thank all the speakers for all the different episodes and all the delegates. I also want to thank Team Globusel headed by Mr. Chadda, Dr. Manoj Kumar and the team, and for the superb networking and continuous support for this Knowledge Academic Fest. And also I must thank enough to my colleague, course director, Professor Dr. Lakshmi Narasimhan for wonderful efforts to make this plan successful. So friends, we'll meet also next month and all coming months. Today, let's enjoy with Dr. Shiv Kumar's team from Salem, Tamil Nadu. Dr. Shiv Kumar, it's all yours now.
Sir, I will directly go for the presentation, sir. That I'll ask my resident to present the case of neuromuscular disorder now. Can go ahead, Divya.
Thank you, sir, for giving me this opportunity to present in this forum. I'm Dr. Divya, neurology resident from Salem Medical College, Tamil Nadu. I'm going to present a case of neuromuscular disorder, diagnostic and therapeutic challenges. Next slide. Next slide, please. Yes, sir. I'm presenting a case of 27 years old female, right-handed individual, studied up to 12th standard, a homemaker residing at Salem, has come with chief complaints of. Next slide, please. Weakness of all four limbs for 3 months duration and difficulty in breathing for 3 days duration. Next slide. History of presenting illness. The patient was apparently normal 3 months ago. Then she developed weakness of bilateral lower limbs in the form of difficulty in getting up from squatting position and climbing stairs and difficulty in walking for 1 week duration. There was no history of weakness in the upper limb, no sensory or bladder disturbances at that time. She was treated and had partial improvement with steroids, but got discharged at request before coming to a full diagnostic workup with initial diagnosis as Cori AADP, and there was no further follow-up visits after that. Now she again admitted with these complaints. Next slide, please. Over a period of 2 months, she had progression of her weakness in the form of difficulty in walking with buckling of knees and difficulty in getting up from even bed or chair. She needs a caregiver support for even standing or walking. And there was history of flailness of both lower limbs, but there was no history of slippage of chapels or dragging of foot. Now for the past 3 days, she was not able to even stand or walk even with support. Next slide. Able to rise both arms above the shoulder level, but there was difficulty in lifting heavy objects present. There was no history of difficulty in bringing the food to mouth, able to hold the objects tightly and able to mix the food and open the door handle and bottle caps. There was history of difficulty in lifting head off the pillow, and there was a history of difficulty in turning in bed from side to side. Next slide. History of difficulty in swallowing both food and water associated with occasional regurgitation for past 10 days duration. There was no history of hoarseness or nasal drawing in voice. History of breathing difficulty present for 3% at rest and exaggerated on exertion. There was no history of chest pain, palpitation, cough, no history of any abdominal distension. Next slide. No history of any diurnal variation of the weakness, no history of thinning or twitching of muscles, no history of tremulousness, no history of difficulty in releasing hand after handshaking, or no history of worsening of weakness on cold exposure or after fever or stress, no history of muscle pain or cramps at rest after exercise, no history of any discoloration of urine. Next slide. She is able to appreciate smell, able to see near and distant objects clearly, able to appreciate colors, able to look into all directions, no history of drooping of eyelids or double vision, able to feel the sensation over the face, chew foods, and able to appreciate the taste, no history of any facial asymmetry, able to hear well, no tinnitus or giddiness, able to turn the head sideways, able to protrude the tongue and marshal the food inside the mouth. Next slide. Able to feel the sensation of cloth, able to feel pain, hot and cold water while bathing, no history of neck pain, back pain or radiating pain, no history of constricting band-like sensation, tingling, numbness, pins and needles or burning sensation in extremities, no history of incoordination in the dark or feeling the ground like cotton wool or electric shock-like sensation while flexing the neck. Next slide. No history of any bladder or bowel disturbances, no history of abnormal sweating, no unsteadiness or swaying while sitting or standing, no history of food or water when bringing to the mouth, no history of slurring involuntary movements, no history of altered sensorium or loss of consciousness, no history of fever, headache, vomiting, seizures, no history of skin rash, joint pain or swelling, no history of any drug or toxin exposure, no history of dog bite or recent vaccination. Next one. Birth and developmental history was normal, and past history there was no known comorbidities. Treatment history, she went into for homeopathy treatment for the past 2 months. Personal history, she takes mixed diet, and last menstrual period was 3 months ago. She has 3 children and normal vaginal delivery. And family history, she was of non-consanguineous marriage, no similar illness in the family members. Next. Summarizing, a 27 years old female patient with subacute onset progressive flaccid quadriparesis, proximal symmetrical weakness, lower limb more involved than upper limb, without any thinning or twitching, without fluctuation or diurnal variation of weakness, along with neck and trunk muscle weakness, swallowing and breathing difficulty, without involving extraocular, facial, higher mental functions, sensory, cerebellar, extrapyramidal, and autonomic nervous system. Next slide. So my localization will be, it's an element type of quadriparesis involving the bulbar and respiratory muscles. Next. So the probable location could be next. Next slide. Next. So probable localization could be either in the muscle or motor root or neuromuscular junction. The points in favor of muscle is the proximal symmetrical weakness and weakness more than wasting. There is no wasting anything. And points against muscle involvement is the bulbar involvement is not so common in a muscle disease. Motor root, the points favoring motor root are progressive symmetrical proximal weakness and lower limb more than upper limb, ascending type of progression. Points against is there is no distal weakness at all. Though in motor root we say proximal and distal weakness. Neuromuscular junction, the points in favor are respiratory and bulbar involvement. Points against are the extraocular muscles are not affected. There is weakness. So among these 3 anatomical localization, the possible etiologies could be in muscle, it could be a metabolic or endocrine myopathy, inflammatory myopathy, CIDP variants. In neuromuscular junction, it could be one of the CIDP variant, or in neuromuscular junction, it could be a with a limb onset in myasthenic crisis, or it could be a Lambert-Eaton myasthenic syndrome. Next slide. Shall I proceed examination? General examination. She was conscious oriented, dyspneic, tachypnic, no paralysis, clubbing, edema, lymphadenopathy, no facial dysmorphism, no neurocutaneous, no signs of vitamin deficiency, no thyroid swelling, no skin rash, joint tenderness, no peripheral nerve thickening. Next slide. Vitals. Pulse rate was 120 per minute, regular, normal volume and character. All peripheral pulses palpable. Respiratory rate 26 per minute, regular. Saturation was 97% in room air. Blood pressure was 90 per 60 millimeter of mercury, and single breath count was only 7. So she was immediately intubated in view of poor respiratory effort and was connected to mechanical ventilator. Next slide. Coming to cranial examination, Sol fraction was normal. Visual acuity, fundus normal. Bilateral extraocular movements were full. There was no ptosis, no nystagmus. It's normal. And optokinetic nystagmus, normal response. Direct and indirect light reflexes were normal bilaterally. Sedation over the face was normal. Motor examination could not be performed in detail due to the intubation. Bilateral eye closure was weak. However, facial asymmetry noted. Hearing was normal. 9th and 10th could not be intubated. Able to shrug both the shoulders and turning neck against resistance could not be performed. Tongue, there was no atrophy or fibrillations. Next slide. Coming to spinal motor system extension, bulk was symmetrical on both sides. There was no wasting or fasciculation, no tenderness of the muscle, tone, normal in the limb, and hypotonia in the lower limbs. Coming to power examination, bilaterally symmetric power, shoulder abduction, adduction, internal and external rotation are 4 minus, adduction and extension grade 4, MRC grading 4. Next slide. Wrist flexion and extension were plus. Next. Coming to lower limb power examination, hip flexion, abduction, adduction was grade 2, knee flexion and extension grade 3, ankle dorsiflexion and plantar was grade 4. There was no percussion. Fatigability test, the sustained arm abduction, she cannot sustain for more than 60 seconds. Leg elevation is not possible. Neck elevation also not possible. No ptosis on even after. Showing facial and limb weakness. Shall I show video if it is not playing? Or shall I proceed with the examination, sir?
Yeah, extraocular movements normally just carry on. Continue.
Present.
Divya, your voice is not audible.
Present but diminished. Knee jerk present normal. Next slide. Sensory examination was normal. Finger nose test was normal bilaterally. Gait coordination involved cranium normal. Next.
Ma'am, can you switch off your video? Because I think there is some connectivity problem is there. Yeah, now you can speak because your voice is not coming properly. Yeah, you can start, ma'am.
Other system examination declared non-homogeneous, but normal, and the terminal also normal. Next slide. Summarizing 20-years-old female with flaccid versus lower limb more than upper limb involvement with symmetrical proximal trunk weakness, bilateral facial weakness in the form of bulbar weakness, respiratory involvement, along with hypotoxia, fatigue, with intraocular higher mental function, sensory cerebral nervous system.
At this point of time, can you discuss the possibilities that what was the initial diagnosis that when a patient got admitted 3 months ago, then that was what was the diagnosis initially, then later on after 3 months, what has happened? And that time, what is our thinking? Can you just discuss about it? Divya, are you online?
I think Dr. Divya is not there.
Sir, the thing is that I will discuss, sir, that initially this patient has come and got admitted and stayed for about 5 days. And initially it was.
Divya is there. Divya is there online. Divya Selvaraj, no?
Yes, sir. Sir, initially this case when she was admitted of paraparesis alone, only for motor, the diagnosis for the ADP, sir. And started treating with we had some improvement, sir, but partial improvement. She was never back to base. Investigations were done. So after till this admission, sir. But now this time the admission showed quadriparesis, flaccid quadriparesis involving lower limb more than upper limb, along with the facial weakness and bulbar and respiratory muscle weakness, along with that hyporeflexia also, sir. So now the possible localizations are, next slide. So while taking into consideration whether the fatigability into account, we thought it as neuromuscular could be still motor root due to that hyporeflexia, or least likely it could be muscle also. Next slide. So according to this available examination findings, differentiating between these three anatomical localizations, proximal more than distal weakness is in favor of muscular junction and muscle in motor root, or can be proximal more than distal also. Coming to lower limb more than upper limb rather than the neuromuscular junction or muscle also it can be there. But in neuromuscular, myasthenia gravis myasthenia, where more than upper limb. Coming to symmetricity, sometimes is motor root and neuromuscular junction in limbocyte. Seen in neuromuscular junction as well as in the root, but the absence of process in this case will favor than a neuromuscular junction. Fatality will favor.
I think we lost her voice again because the video is
Yes.
Divya, are you on line?
Yes, sir.
So this patient has presented initially with quadriparesis ascending type of paralysis with reflexus flaccent. And that time now conduction studies were done which were normal. So based on that ascending paralysis, the diagnosis of GBS was made. Patient was treated with methylprednisolone. Patient had some partial improvement. Patient wanted to go home, so the patient has gone with the steroid oral treatment. And the patient has gone somewhere else for homeopathic treatment. Then she returned with increased weakness. This time again that she had both lower limb and upper limb, proximal more than distal weakness, with the lower limb more involved than upper limb. But reflexes are hyporeflexia, but they are intact. Patient predominantly had bulbar weakness without any extraocular muscle weakness, no ptosis, no extraocular eye movement weakness. So the diagnostic dilemma is whether we are dealing with a neuromuscular junction disorder, that is unusual form. The limb variant of a neuromuscular junction disorder along with the bulbar palsy without extraocular muscle involvement. Yes, we know that extraocular muscle involvement ptosis are the common presentations in myasthenia, but this patient is an unusually as presented with the limb and bulbar variant of neuromuscular junction disorder. We have got only a fatigability sometimes plus or minus present, but in the power of 2 to 4, the fatigability is questionable. So another thing is whether the patient has developed a recurrent AEDP or CEDP like presentation. That is also, that diagnosis also we had in mind. Then another thing is whether we are dealing with any myositis. With all three diagnoses we entertain, we have gone for investigations further.
Shall I continue?
Any discussions are regarding the decision regarding the diagnosis at this point of time? Sir, Lakshmi Narasimhan, sir. Shall we go ahead with the investigation, sir?
Previous slide.
Go ahead.
Yes, sir. Previous slide.
Sri Kumar, please go ahead with the further investigation.
So among these three anatomical localization, the differentials could be CIDP variant with bulbar or cranial neuropathy could seen in 20% of cases. That could be any nodoparanodopathies or chronic ataxic neuropathy. But there will be a sensory involvement will be predominant in these conditions, and they will be confirmed by a nerve conduction study and antibody testing. But there will be poor response to steroids and IVIG, and treatment of choice will be rituximab. Next slide, please. A muscle with a respiratory or bulbar involvement could be inflammatory myositis or thyroid myopathy. And adult onset Pombe's disease and mitochondrial myopathy, though very rare, can also be a possibility. Next slide. A few points about adult onset Pombe's. It could be present like truncal and proximal limb myopathy and will be slowly progressive over years. Death will be due to respiratory muscle weakness. Sometimes respiratory weakness may be the initial presenting feature. So that this Pombe's can be a differential diagnosis for motor neuron disease, Himalayan myopathy, or even myasthenia gravis. In Pombe's disease, the CPK can be normal or slightly elevated. The EMG will show fibrillations and positive sharp waves, high frequency discharges, and occasional myotonic discharges. Next slide. Coming to neuromuscular junction with bulbar or respiratory involvement, it can occur either with autoimmune myasthenia or congenital myasthenia or even Lambert-Eaton myasthenic syndrome. Next slide. A few words on congenital myasthenic syndrome. Presenting till adulthood, it could be either acetylcholine receptor deficiency or it could be a slow channel mutation, a non-fluctuating limb girdle pattern of weakness. Either it could be a DOX7 mutation or GFPT1 or DPACT1 mutation. Weakness that worsens with pyridostigmine or in slow channel mutation and DOX7 mutation. In those conditions, the treatment of choice will be salbutamol and fluoxetine. Next slide. Coming to it begins with previous. Coming to limbs, it begins with proximal lower limb weakness. Previous slide, please. Proximal lower limb weakness, but ocular and bulbar involvement will be rare, and sensory and autonomic nervous system involvement will be common, like dry mouth. reflexes may be depressed and CMAP amplitude may be low in nerve conduction study, and there will be increment after brief exercise or high rate RNS, diagnosed usually by antibodies to voltage gated calcium channel. Next slide. So with these differentials in mind, we proceeded with investigating this patient. Next slide. Next. This was the NCS done 3 months ago. At that time, the NCS was repeated twice and it's normal. Next slide. At that time, in view of demyelination, CSF analysis and MRI whole spine also done. Next slide. This time we could not proceed with NCS or as the patient is on ventilator, we could not shift. So we proceeded with the neostigmin test, and the neostigmin test was positive. I'll show the videos separately from my side. So, other routine investigations were normal, hemoglobin 2-DC. Only the D dimer was elevated. It was in 1665. Next slide. RFT, LFT were normal. Next slide. Thyroid profile free T4 and TSH was normal, but anti-TPO antibodies was highly elevated, suggesting a euthyroid state of thyroiditis, autoimmune thyroiditis. Other CRP was normal and CPK was also normal. LDH was mildly elevated, calcium was low. Next slide. ECG showed sinus tachycardia or progression of R wave from V1 to V4 and T inversion in lead 2, 3 and AVF. Echo showed global hypokinesia of ventricle and ejection fraction was 40%. Moderate LV systolic dysfunction was there. Next slide. Ultrasound abdomen done was normal except for the mild fatty liver and minimal right pleural effusion. Next slide. Proceeded with CT chest that also showed bilateral mild pleural effusion and the consolidation in the right lower lobe and also left lower lobe posterior segment, suggesting it could be a aspiration pneumonitis. Next slide. So we proceeded with the acetylcholine receptor antibody that was highly positive. The reference value was 0.4 and the patient had more than 8 nanomoles per liter. So proving this to be a autoimmune myasthenia gravis. Next slide. So diagnosis was generalized myasthenia gravis, class 5 in myasthenic crisis, autoimmune thyroiditis along with dilated cardiomyopathy. Next slide. So course in the hospital, this patient was treated initially with the plasmapheresis. 2 cycles since she had cardiomyopathy also, but then she went in for hypotension and was treated with the double inotrope support with noradrenaline and dopamine infusion. After a week, she was done tracheostomy and again connected to the ventilator. And she again received a treatment with the IV immunoglobulin. In due course, the patient developed a cardiac arrest twice and she was revived with CPR. Next slide. Then patient limb power improved, but her neck weakness still persisted and we could not extubate her from ventilator. So she started on pyridoxine also 60 milligram once every 6 hourly. Along with she developed in due course pneumonitis also, aspiration pneumonitis, and they her from ventilator. So she stayed on ventilator for nearly a month. After the patient went in for a and finally she died. That's what we heard from the attenders. This is a video slide again. With going in for review of literature video, I will show it from my side after PPT. Cardiac manifestations of myasthenia gravis. This could be either due to associated thyroiditis, or it could be due to anti-strational antibodies seen in the myasthenia itself, severe myasthenia, or it could be a stress-induced cardiomyopathy like Takotsubo cardiomyopathy or giant cell myocarditis. Next slide. The only odd point in this case was of generalized myasthenia along with bulbar and respiratory, along with facial weakness also. Still, the extraocular muscles are not involved. So there are some few case reports on this with late onset general myasthenia presenting with facial and bulbar without extraocular muscle involvement. Next slide. This is also one more case report showing bilateral facial palsy without ocular and muscle involvement in myasthenia gravis. Next one. Shall I share video from my side, sir?
If it's possible, you share it. If your video or computer is playing well, the video can share it.
Yes, sir. This is the video showing extraocular movements. Was fully normal.
No, the video is not coming. I think maybe I can stop it. The video is not coming.
Now, sir.
Not video. Only the pictures comes. There is no video.
கொஞ்சம் டைட் கொடுங்க சரி கை தூக்குங்க தூக்கு சரி கால் தூக்கு கொஞ்சம் கூட தூக்குங்க அந்த கால
The initial presentation.
Divya, I think you can stop this video and discuss the case.
Sir, after me. It is after me. The power immediately injured after taking.
கால் தூக்குங்க அந்த கை தூக்குங்க சரி 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 கண்ணு மூடுங்க கொஞ்சம் டைட்டாக மூடுங்க டைட்டாக மூடுங்க
Divya, there is no display of video. Just you stop it and discuss this.
Yes, sir. That's from my side, sir. So initially we thought this could be either recurrence of AADP or myasthenia presenting without extraocular involvement. So with this neostigmine test and acetylcholine receptor antibody, we confirmed this diagnosis of myasthenia. after even after diagnosis and even after treating with the plasmapheresis and IVIG also, I had many hurdles in her due to the associated cardiomyopathy and associated pneumonitis also, sir.
So we have got a patient who presented with an immune-mediated disorder involving the neuromuscular junction, mainly the lower limbs and upper limb bulbar onset, without even a trace of extraocular muscle involvement. That is the reason that we have presented this case. Though it can occur, but it's unusual to have only the limb involvement as well as bulbar involvement without even that. In the progression also, there is no extraocular muscle involvement or ptosis. That is point number one. Second thing is the associated thyroid disease, that is autoimmune thyroiditis, as evidenced by increased thyroid peroxidase antibody. And another thing is that a cardiac problem. There is a patient that had a cardiomyopathy with the ejection fraction of 40. So all these problems are adding problem to the management of the patient. And we know that there is patients will improve with the plasmapheresis within a few days of giving a plasmapheresis. But in this patient, unfortunately, we have not had any improvement of bulbar weakness. So we could not wean the patient. And we have also switched over to immunoglobulin because the patient had a cardiac problem. So we could not continue plasmapheresis. So we have switched over to immunoglobulin also. And we try to put her on pyridostigmine and neoxylamine also to make her, trying to wean her from ventilator, which we could not do. And the patient, once it becomes sick and the patient has gone on AMA against medical advice and died at her home probably. So this is in spite of, we have diagnosed this case in the second admission and they are given a proper treatment with plasmapheresis and as well as immunoglobulin and anticholinergic drugs. The patient has not shown any improvement. The presentation is very florid with severe weakness. So this is the reason we have presented this patient in this forum. So the patients can present with an acute onset of weakness and necessitating intubation and ICU management. And the presentation is variable. We have got cases which are AEDP also can present with so much of variation in presentation, as well as the myasthenia also can present with so much of variation. So we have to check all the parameters available for diagnosing this case at the earliest phase, like myasthenia workup as well as AEDP workup and myositis panel. All these things, if available, we can do and try to arrive at early diagnosis so that we can manage the patients with more carefulness and try to improve this patient. That is the reason that we have presented this patient. And any further discussion, I think we are welcome to see the expert's opinion regarding this patient's diagnosis and management.
Dr. C, question in chat box in question answer. Patient's current respiratory compromise better explained by myasthenia crisis or acute LVM due to ischemic cardiomyopathy or both? Dr. Manavendra Bhattacharya has asked this question.
I think the patient had weakness more than cardiomyopathy. We could able to manage the patient with inotropic support as well as that ventilation, and the patient's not showing much of fluid retention in the lungs. So I think that the patient had bulbar weakness, that is pharyngeal weakness, that is the main reason for continuing her ventilation, sir.
So what doctor is asking is whether LVF has contributed to the respiratory failure part to some extent, or you think it's purely myasthenic component?
The contribution of LVF to this thing is, I think, probably less. The main thing is that she had a myasthenic crisis with the bulbar and the respiratory weakness. That is the main reason. And the contribution of LVF to this problem is less or minimal, sir.
Right.
The patient's problem is probably due to myasthenia itself.
In fact, sir, I just wanted to, for the sake of posing, in fact, I had 2 cases of Takotsubo cardiomyopathy in case of myasthenia. when they, after the, in fact, immediately post crisis, managing the bulb crisis, during the management of the bulbar myasthenic crisis, the patient had a very low EF. Then we did a echo. Echo showed a typical that apical, the jugal appearance, and then we confirmed the diagnosis of Takotsubo, and then we thought it is coronary. Then we did a angio, so angio negative, typical echo findings, and 2 cases of Takotsubo I have seen, sir. One more interesting thing is, it's quite an interesting case. Thank you so much for bringing this cardiac involvement. Myasthenia per se also involves the cardiac, and the other thing is the extreme stress during the myasthenic crisis can also precipitate Takotsubo. One more interesting thing which I wanted to tell for the sake of postgraduates, myasthenia always will have the pictures will have a type 2. Neuromuscular junction weakness will have a type 2 respiratory failure. When you have a type 1, there can be most of the ARDS will present as type 1. In fact, during this COVID crisis, one of these patients, known myasthenia, had developed a acute fulminant type 1 respiratory failure. That was not due to it was not myasthenic. It was erroneously referred to as myasthenic crisis, but it patient proved to be ARDS with we had to manage the patients for a type 1 respiratory failure. So worth remembering is the neuromuscular junctions always will have a type 2 respiratory failure, whereas primary lung pathologies producing ARDS will have a type 1 respiratory failure. So you're doing an ABG during the early phase will give you a clue whether you are dealing with a type 1 or type 2. Thank you.
ABG that time it was not available, sir, due to some.
No, I'm not. Sir, not in this case, sir. I'm just telling for the boys to learn, not in your case.
Sir, so what about your comment regarding this limb onset bulbar myasthenia, then without any extraocular muscle involvement?
It's quite rare, sir. I have quite rare, very rare, and excellent case, sir. Thank you. Few questions in the question box, sir.
That's what the ABG they asked, sir. That ABG we have not done it, and that because of some technical problem. And other than that, why plasma cycles only 2 cycles? Because of cardiac problem and hemodynamic instability, we could not proceed with plasma paresis. So we switched over to intravenous immunoglobulin instead of plasma paresis.
Thank you, sir.
And the other regarding this myasthenia, I have another one doubt, sir. That is that it's a post-synapse problem, that is acetylcholine receptor problem. Why some patients present with the extraocular, that is a known presentation. Why some patients will have only limb onset? What is this peculiar that patients to have only the limb onset or bulbar weakness without showing any extraocular muscle problem? Is there any muscle-specific disease is there, that is antigen antibody response, which affects only bulbar muscles and limb muscles, not the extraocular muscles in some patients? And the majority of patients have a limb, that is extraocular muscle ptosis. Majority, we have explanation for that being a smaller muscle, smaller neuromuscular unit, that ptosis and extraocular muscle involvement is more common in myasthenia. But why some patients without that they have? I don't know the answer for this, but I could not get also. If anybody have idea that why some people have only that particular involvement, varied presentation. Any explanation for this, sir? Is there anything available in literature that
I do not know, but it all basically, I mean, I do not know, sir. I do not know. But I thought if anyone of us in the group knows about it, can highlight us. But why extraocular muscles are spared in certain cases, I mean, I'm not aware. But in MuSK also, the involvement of in MuSK, see, it all based on basically some receptor distribution, which we don't understand. And in the extraocular muscles, we know that there are the fibers, there is a certain type of fetal fibers, the different kind of receptors which can be the cause. That is the cause for the sparing of these extraocular muscles in certain case of in amyotrophic sclerosis. But as far as the myasthenia is concerned, is there any difference in the receptor configuration of the extraocular muscles? I'm not aware, sir. I'm not sure. Okay.
Hello. Yeah,
Sir.
Dr. Shikumar, it was a really wonderful case, and time to time we are aware that myasthenia can present as limb-girdle myopathy syndrome. So it exactly mimics limb-girdle myopathy, and we have seen a couple of good cases with bulbar involvement without extraocular muscle involvement. And the teaching that we pass on to our student is in all suspected muscle cases, always do repetitive nerve stimulation test so as not to miss myasthenia gravis. So this could be a wonderful tip for all PG students. They should all consider RNS, repetitive stimulation, and even test for Eaton-Lambert syndrome in pure muscle cases who have presented even as limb-girdle syndrome. The point that I wanted to ask you is when you have cardiomyopathy, I mean, sometimes it becomes very risky to do plasma exchange. So perhaps I would have considered directly gamma globulin followed by some steroids. That is one thing. Second comment rather was when you have antithyroid antibodies in the range of anti-TP only 109. I mean, all the panelists I'm asking, how much importance do we attach to anti-TP or antibody levels, particularly when it is a range of 100, 130, and 200? Because sometimes I find it very non-specific, and how much importance do we need to attach? Dr. Shiv Kumar, Dr. Lakshmi, both can attend this.
And we are not given any importance to this thyroid peroxidase antibody.
Yes, sir. As you rightly said, it is definitely non-specific unless it is in a very high significant titers. The second thing is, sir, in presence of a cardiomyopathy, Professor Bala sir, since he is in charge of the muscle and now, he has designed that low volume plasma exchange. Around, in fact, we have done even 30 ml, sir. 30 ml range also we have done. Yeah. And with more over a spread out period of longer period of time, has helped in patients with sometimes with cardiac illness with myasthenia. So what we do is a very low fraction plex is definitely helpful in a settings where IVIG is not frequently available. In a governmental setup, it is very difficult, sir. It's not so freely available. So in that such compromise situation, we go in for a low volume plex. That is one thing, sir. And TPO, as you said, it is non-specific and we don't attribute much importance for that.
Yeah. So having said that, this low volume plasma exchange is a nice technique and is almost like CRRT as we do. And our unit in private hospital also has tried that. I think it works. So that was one of the things which I was planning to tell in the next part of my talk. And second thing was regarding gamma globulin. I think now government has made it available in under the scheme of PMJ or the Ayushman Bharat. So most of the centers, to my knowledge, in India would be now having free gamma globulin under the cluster. So I don't know what is the status in your state, but in our state, we are lucky enough to have gamma globulin if the patient.
For us, the load is so high. For example, the 1 year gamma globulin allotted for us has been blown away in 5 months. And 1,800. See, the patients, sir, most of the patients can't afford in a private setup for 3 lakh injections. So
Right.
almost in Chennai, each week we get about 4 to 5 GBS cases. We have a separate ward for GBS, sir. So neurorespiratory is
That's a practical problem. I do
Yes, sir.
agree.
Yes, sir.
And only our preparators, these fellows, gamma globulin people, globusel people, I think Mr. Chadda can have some plan for free plasma, free gamma globulin across the country, or maybe at a concessional price. Mr. Chadda, what is your take on this?
Definitely, sir, definitely.
So can we look for some concessional or free slots of plasma? I mean, gamma globulins. I will be happy to have that generous contribution from you and your company. What do you say, Dr. Lakshmi?
Yes, sir. They can, in fact, very genuinely sick patients, very poor, not affordable. They can always have a on the corporate social responsibility can try to get supply something. Already they are doing it, sir. Whenever we ask some free vials for a few patients, Chadda is generally very generous and gives us. There's no issues on that.
So we appreciate your help, Mr.
Yes, sir.
Chadda. And we
Sir,
hope
next month meeting is with GB Pant, sir. Professor Debashis has agreed, sir. And one more thing, one more interesting feature which we are planning to introduce next thing is, as you said, that one investigation will be dealt in detail, sir. We are first starting with the MR focused ultrasound with case demonstration by Vijay and also the next meetings.
right. So Coimbatore people have agreed.
Yes, sir. Coimbatore.
Yeah,
And after the clinical case discussion, there will be a presentation on MR focused ultrasound.
So maybe 15-20 minutes.
Yes, sir.
Wonderful.
Half an hour. I have told them half an hour. Thank you.
Great, great.
Thank you.
The most important
Sir,
part.
there is
Thank you.
one, Dr. Bala's presentation is also there, sir. Dr. Bala?
The topic presentations are regarding this patient myasthenia. Shall
Oh.
we proceed or?
Yeah, please.
Dr. Bala, please present your presentation. Yeah, please.
Dr. Bala, make it short because the time is already more than an hour.
No, we thought there was I had announced his name, but since he did not appear, I thought he is not likely to present. Anyway.
Good evening, sir. Thank you for giving me this opportunity, sir. Just I would like to give a brief review of myasthenia gravis clinical presentation and management, sir. Are my slides visible, sir?
Visible, go ahead.
Yes, Dr.
Thank
Bala, you go ahead, please.
Thank you, sir. So myasthenia gravis first recognized by Thomas Willis, of Oxford physician in the 17th century itself. Then bulbar palsy without any anatomical lesion was first identified by the Erb and Wolfram. So it is called Erb-Wolfram syndrome. And Jolly was the first person to name the myasthenia gravis pseudoparalytica. This is an autoimmune disease affecting the neuromuscular junction and causing fatigable ocular, limb, and bulbar muscle weakness, affecting the all age groups. Peak age is 20 to 30 years in women and 50 to 60 years in men. And less than 30% affects the children. With thymoma, majority are older individuals, like 50 to 60 years of age. And there is familiar occurrence also noted. The fundamental effect is antibody-mediated T-cell dependent immunological attack on the postsynaptic membrane. So this results in the damage of the postsynaptic membrane, reduced number and density of acetylcholine receptors, and postsynaptic folds become flattened, and finally decrease in the efficiency of neuromuscular transmission. So even if the acetylcholine release is normal, it produces small endocrine potentials, so it fails to trigger the muscle action potentials. And this failure of transmission at many neuromuscular junctions results in weakness of the muscle contraction. So the amount of acetylcholine released per impulse normally declines on repeated activity. That is called presynaptic rundown. In myasthenia gravis, this presynaptic rundown, along with the decreased efficiency of the neuromuscular transmission, causes the weakness, increased weakness, that is myasthenic fatigue. And this is classically seen in decremental response to RNS. So pathophysiology is the acetylcholine receptor antibodies. They cause impairment of transmission by cross-linking, causing internalization, degradation of acetylcholine receptors, or complement-mediated destruction, or blocking the acetylcholine to bind to the acetylcholine receptor, or decreased number of acetylcholine receptors at the NMG junction. So what is the role of thymus in myasthenia gravis? So in thymus, there are epithelial myoid cells normally present, which resemble the skeletal muscle cells, and they possess the extracellular receptors on the surface. So these extracellular receptors, sometimes they become antigenic and unleash the autoimmune attack on the muscle end plate extracellular receptors. So by the process by molecular mimicry. So in myasthenia, almost 75% will have thymic disease. That is 65% will present with thymic hyperplasia and 10% will have thymomas. The clinical presentation, as we all know, it is fluctuating disease with effort and rest. So initial presentation in myasthenia may be in 1/3 of patients may have ptosis and diplopia, that is ocular involvement, and 1/6 will have bulbar involvement also. 10% will have limb weakness also. And very rarely they may have single muscle groups involvement like triceps, deltoid and all. So early symptoms, which are the early symptoms to identify myasthenia gravis, they will have frequent purchase of new glasses for the correction of blurring of vision like diplopia. And they will avoid tough and fibrous foods chewing. They will avoid reading newspapers or watching TVs for long time or driving the bright sunlight. They will avoid activities like singing activities. And the friends also notice sleepy or sad face. The factors which worsen the myasthenia gravis, or maybe sometimes the initial presentation of myasthenia gravis, are systemic illness like fever, URTI, thyroid like hypothyroid, hyperthyroid, pregnancy, menstrual history or surgery or drugs. In drugs, the most common drugs usually we use that worsen the myasthenia gravis are antibiotics like macrolides, aminoglycosidase, fluoroquinolones, erythromycin, anti-malarials like chloroquine, hydroxychloroquine, quinine, iodinated contrast, beta blockers, magnesium, procainamide, steroids which worsen myasthenia gravis in the first 1 or 2 weeks of starting steroids in myasthenia, statins, Botox, and depensilamine, desferoxamine. The course of myasthenia gravis is it is a progressive disease. It restricts to ocular muscles in 10 to 15% of cases, and they say that if it is limited to ocular muscles for a period of at least 2 to 3 years, then 90% will not become the general myasthenia. And the maximum weakness we observe in myasthenia gravis is in the first year, that is 2/3 of patients. And they told that 1/3 may improve spontaneously, and 1/3 of patients will worsen, and 1/3 patients will die. Theoretically, they told if the myasthenia have 2 phases, like active phase and burnt out phase. Active phases which have symptoms typically fluctuate in short period and then worsen rapidly. And burnt out phase is very rare, usually very rare nowadays, because burnt out phase is seen in untreated patients which become fixed for many years, and the more severely affected muscle become atrophic. Why the myasthenia affects only the specific muscle groups? Because the most common muscles affected in myasthenia are ocular muscles, bulbar muscles, or laryngeal muscles. Because these muscles have low innervation ratio, that is very few fibers per motor unit are innervated. So the few fibers are innervated. So if few fibers are lost, then the muscles are affected, or actively contracting muscles like in ocular muscles or bulbar muscles. So coming to ocular myasthenia, that is asymmetrical weakness, not attributable to any cranial neuropathy, and most common and most severely affected muscle is medial rectus, and ptosis is asymmetrical and alternating ptosis, like left and right. And diplopia will be binocular diplopia, horizontal or vertical, and pupils are classically sprayed in ocular myasthenia, and there will be pseudo-INO, that is differential weakness of medial rectus and lateral rectus, causing adduction palsy and contralateral abducted nystagmus. Fever is also seen when we ask the patient to look like saccades, produce saccades, the patient will have nystagmoid jerks. And what are the early signs or mild myasthenia gravis, ocular myasthenia is? Patient will have unilateral frontalis contraction. Patient will tilt the head backwards to see the others, or patient will have weak eye closure only, or bifatigable test. Signs like curtain sign, Kogan twitch sign, peak sign are classical of myasthenia gravis. Coming to oropharyngeal muscle weakness, bulbar muscle weakness, we see it is more commonly seen in anti-musk antibodies. Palatal muscle weakness, if it is present, patient will have nasal voice, nasal twang of voice, nasal regurgitation, chewing difficulty. Like classical jaw drop will be there if there is jaw muscle weakness. Patient will have studious or attentive posture, and swallowing difficulty, aspiration of fluids, coughing, choking, clearing throat while drinking, and there will be trident tongue in myasthenia. Among neck muscles, neck flexors are classically weaker than extensors, but rarely extensor weakness is also seen. That is called the dropped head syndrome. Among the trunk muscles, commonly the erector spinae muscles are affected. Among the limb muscles, upper limbs are most commonly involved than lower limbs. Among them, proximal is more commonly involved the distal muscles and asymmetrical, classical asymmetry. Upper limbs, deltoids, wrist extensors, finger extensors, triceps are commonly involved. Lower limbs, hip flexors most commonly involved. Quadriceps, hamstrings, foot dorsiflexors commonly involved. Intercostal muscles also involve diaphragmatic muscles, abdominal muscles, external sphincters of the bladder and bowel also involved. Atrophy is very rare. It is in the late stages, especially in the muscle myasthenia. And the smooth and cardiac muscles are not involved. Tendon reflex are retained and parasticias are noted, but sensory is normal. The common autoimmune disease affecting myasthenia, coexisting myasthenia, Hashimoto's thyroiditis or thyrotoxicosis, that is 10% of myasthenia gravis patients, rheumatoid arthritis, SLE, scleroderma, Jogren's, and polymyositis. So this is a slide showing the types of myasthenia gravis that are ocular, early onset myasthenia and late onset myasthenia, thymomatous myasthenia, muscular myasthenia, and LRP4 receptor myasthenia and seronegative myasthenia. Among ocular, as we know, that is acetylcholine receptor positive, that is 50% of the patients will have acetylcholine receptor positive. Early onset, late onset. Early onset is the one that will have less than 40 years, and late onset more than 40 years. Early onset will have hyperplasia thyroid, whereas in a late onset, thymus will be normal mostly. And the acetylcholine receptors, apart from the acetylcholine receptors, titin and rhinodine receptors will be positive in the late onset. And late onset is the one which is severe and is common in the females. Thymoma occurs usually in the 40 to 60 years of age, like in older age group, and thymus neoplasm will be there. In thymoma also, all the receptor antibodies will be present. And it is associated frequently with paraneoplastic syndromes. And coming to majority of the patients will be less than 40 years of age, and thymus will be normal. And these have mainly female preponderance, and selectively oropharyngeal muscles, facial muscles, respiratory muscles are involved. Coming to LRP4 myasthenia, this is a rare entity showing LRP4 antibodies positive, response to therapy similar to the acetylcholine receptor antibodies. Coming to seronectomy means negative to both acetylcholine receptor and MuSK, and there will be some patients will have thymus hyperplasia. So coming to MuSK myasthenia gravis, antibodies to MuSK have been found to be present in 50% of acetylcholine receptor negative patients with generalized myasthenia, and their presence is useful diagnostic test in these patients. So more pronounced bulbar weakness and tongue and facial atrophy will be there in myasthenia, MuSK myasthenia. And they may have neck muscle, shoulder muscle, respiratory muscle involvement without any ocular weakness. They are also less likely to respond to acetylcholine esterase inhibitors, and their symptoms may sometimes aggravate with these acetylcholine esterase inhibitors. So coming to MGFA classification, Myasthenia Gravis Foundation of America classification, clinical classification, they have done classification. Class 1 is only ocular muscle involvement. Class 2 is mild. Class 3 moderate. Class 4 severe weakness. Among this class 2, 3, 4, they have divided 2A, 2B. 2A is predominant limb axial muscle of both. 2B is oropharyngeal respiratory muscle involvement. And class 5, they have done it is intubation or with or without ventilation, like NIV support. So for quantitative estimation of myasthenia gravis, we can do clinically by quantitative myasthenia gravis score that they have taken almost 10 parameters, like double vision on lateral gaze for 60 seconds, ptosis on upward gaze for 60 seconds, eye closure, swallowing half cup of water, speech after counting allowed from 1 to 50, and both arms left and right outstretched at 90 degrees for 240 seconds, both legs left and right outstretched for 45 to 50 degrees for 100 seconds, force vital capacity, bilateral hand grip for 45 seconds, and head lift at 45 degrees for 120 seconds. So this is the quantitative myasthenia gravis score. Coming to workup, detailed history and clinical examination, IcePack test and hydrophonium test or neostigma test will be helpful. And laboratory test like anti-acetylcholine receptor radioimmunoassay. This is 85% positive in generalized myasthenia and 50% only in ocular myasthenia. And 50% of those acetylcholine receptor antibody negative patients with generalized myasthenia will have MuSK myasthenia. Coming to RNS, commonly done RNS done in the myasthenia gravis patients, the decrement of more than 10% at 3 years is highly probable, but it is seen only in 53 to 89% of generalized myasthenia and 48 to 67% ocular myasthenia. Single fiber electromyography will be positive in all the patients of myasthenia, but it is not specific. And we can do other tests like thyroid function, chest imaging to rule out thymoma. So treatment is individualized according to the extent of disease or severity of disease or presence or absence of the concomitant diseases. So treatment is symptomatic treatment with cholinesterase inhibitors like pyridostigmine, short-term immune therapies like plasma exchange or intravenous immunoglobulins, long-term immune therapies like corticosteroids, prednisone, immunosuppressant drugs like azathioprine, mycophenolate mofetil, cyclosporine, cyclophosphamide, tacrolimus, and methotrexate. Coming to international consensus of guidelines for management of myasthenia gravis, Symptomatic treatment. Phytostigmine becomes is a part of the initial treatment in most of the patients, and the dose is adjusted as needed based on symptoms. So corticosteroids or immunosuppressive therapy, these are used in all patients with myasthenia gravis who have not met treatment goals after an adequate trial of phytostigmine. That non-steroidal immunosuppressive agent should be used alone when corticosteroids are contraindicated or refused. This non-steroidal immunosuppressive agent should be added to corticosteroids when steroid side effects are significant by the patient or treating physician, response to trial of corticosteroids is inadequate, or corticosteroid dose cannot be reduced. Coming to non-steroidal immunosuppressive agent in myasthenia gravis, cyclosporin is less useful because of potential serious adverse side effects like nephrotoxicity, hypertension, and mycophenolate mofetil and tacrolimus both are widely used. Once the patient achieves the treatment goals, the steroids should be gradually tapered. In many patients, continuing the low dose of steroids for long time will be helpful for the treatment goal. For non-steroidal immunosuppressive agents, once the treatment goal have been achieved and maintained for 6 months to 2 years, the dose can be tapered slowly but less frequently over a period of 3 to 6 months. And this international consensus guidelines for myasthenia gravis also suggests rituximab as an early therapeutic option in patients with MuSK antibody positive myasthenia gravis who have unsatisfactory response to the initial immunotherapy, and it is also effective in refractory acetylcholine receptor positive myasthenia. And they have also told methotrexate recently in 2020 update, like it can be used oral as a steroid sparing agent in generalized myasthenia gravis, and eculizumab also they have suggested it can be used for severe refractory acetylcholine receptor antibody positive generalized myasthenia gravis. The definition of refractory myasthenia gravis is post-intervention status is unchanged or worse after steroids, and at least 2 other immunosuppressive agents have been tried with adequate doses and with adequate duration, but the symptoms are persisting or side effects are limiting. So treatment is with we can try with other immunosuppressive agents, or chronic IVIG and chronic flex therapies we can give, or cyclophosphamide or rituximab. Coming to plasma exchange, it is used therapeutically in myasthenia gravis, and it reduces the levels of circulating antibodies. Course of 5 to 5 exchanges can be given. 2 to 3 liters per exchange can be withdrawn. Then adverse effects like vascular access infection, thrombosis, pneumothorax, and air embolism can be seen. Intravenous immunoglobulins, it is useful in short-term control of acutely worsening myasthenia. Mechanism of action is modulation of the autoantibody response, inhibition of complement activation, decrease membrane attack complex formation, decrease cytokine response, interference with the antigen recognition. The usual dose is 2 grams per kg given in divided doses for 2 to 5 days. Adverse reactions like headache, fluid overload will be classically seen, and aseptic meningitis and renal failure. So according to these consensus guidelines, some experts prefer Plex as a first-line therapy compared to IVIG because onset of action appears to be rapid. And some prefer IVIG because it is easy to administer and there is low incidence serious adverse side effects. So in 2016, they have done this consensus guidelines like Plex and IVIG can be used as short-term treatments in patients' crisis, in patients with preparation for surgery, in patients prior to beginning corticosteroids, because if deemed necessary to prevent or minimize exacerbations. So the choice of Plex and IVIG is individualized because Plex can't be used in patients' sepsis and IVIG can't be used in renal failure, but both are equally effective. But Plex seems to be more effective than IVIG in MuSK myasthenia. Steroids, moderate to severe generalized myasthenia, they are useful when the cholinesterase inhibitors have inadequate response. And the steroids can be started at a low dose, 15 to 20 milligrams, gradually increased 10 milligrams for 1 to 2 weeks, or at high dose like 1 milligram per kg body weight, high dose, then we can continue until sustained response is maintained. That is within 2 weeks, then we can slowly taper the dose. The role of thymectin in myasthenia gravis according to 2020 update is it is done in non-thymomatous generalized myasthenia gravis anti-acetylcholine receptor antibody positive patients. That is in early onset myasthenia gravis, that is 18 to 50 years of age, early thymectin is recommended, and the option was given for late onset myasthenia gravis, 50 to 60 years of age. This will cause increased clinical outcome, decreased immunotherapy requirement, or immunotherapy ineffectiveness can be decreased, or intolerant side effects. And to decrease the need for hospitalization, that is less exacerbations. It is not recommended for ocular myasthenia gravis, or we can delay for at least 2 years for spontaneous remission or development of generalized myasthenia. There is no evidence for MuSK myasthenia or LRP4 positive myasthenia or agrin antibody positive myasthenia. All the patients with thymoma should undergo the surgery regardless of the age to remove the tumor. And MuSK myasthenia, they have given that it does not respond to cholinesterase inhibitors, and conventional pyridostigmine doses frequently induce side effects also. And it responds well to the steroids and many steroid-sparing immunosuppressive agents also. And it will respond well to Plex, while IVIG seems to be less effective. And rituximab is considered as early as early therapeutic option in patients with MuSK myasthenia. They have given a definition for impending myasthenic crisis is rapidly clinically worsening of myasthenia that can lead to the crisis in the short term, that is in days to weeks. And manifest myasthenia is serious life-threatening condition. Rapidly worsening myasthenia, that is potential airway compromise will be there, like ventilation or NAV support with bulbar dysfunction. So according to this, it comes under MGFA class 5, requiring intubation or NAV support. That is commonly seen in generalized myasthenia or thymomorbid myasthenia. And the proportion of patients with myasthenia gravis who experience at least one myasthenia crisis may be as high as 10 to 20%. The annual risk of myasthenia crisis is 2 to 3%, and 13 to 20% patients who present with myasthenia crisis, it is the first manifestation of myasthenia gravis. Most myasthenia crises occur in the first few years of the diagnosis of myasthenia, when the disease is in the most active phase. So precipitating events, like we all know, that infection, aspiration, surgery, medication change. And this elective intubation, that 20-30-40 rule that was previously used, now it is not followed. 20-30-40 rule is 20 is the forced vital capacity less than 20 ml per kg. This is the most consistent parameter we recognize. Forced vital capacity less than 20 ml per kg, and maximum inspiratory pressure or negative inspiratory less than -30 centimeters water, or maximum expiratory pressure less than 40 centimeters water. Additional signs like signs of respiratory distress, progress of hypercapnic respiratory cirrhosis, or inadequate mucus clearance. There is one study done on 44 patients who developed myasthenic crisis. Among them, 63 episodes of myasthenic crisis were reported, and the crisis episodes with generalized myasthenia have 76%, with the bulbar have 19%, with respiratory muscle weakness of 5%. So pathophysiology is in myasthenic crisis, bulbar weakness will be there, respiratory muscle weakness will be there. Bulbar weakness causes alteration of cough and swallowing reflexes and accumulation of secretions. This will cause atelectasis, microaspiration, increase upper airway resistance. Thereby it may cause pneumonia or hyperventilation, that is increasing dead space, and decreased tidal volume. These both cause hypoxemia and hypercarbia, like cirrhosis type 2 respiratory failure. Treatment is Plex or IVIG, and while weaning from the ventilator, cholinesterase inhibitors should be reintroduced very slowly. And treatment with steroids can be initiated if necessary. So they study the treatment of myasthenia gravis exacerbation with IVIG. They have done compared dose of IVIG 2 grams or 1 gram. They told that there is no significant difference in primary outcomes. And how to choosing therapies, clinical efficacy, and patient comorbid conditions. One more study done in myasthenic crisis clinical study group. They have taken 87 patients with myasthenic crisis with either IVIG or Plex. They found that 50% of patients reach target point 20 in plasma exchange group by day 9 and in IVIG group by day 12. But there is no difference in functional outcome at day 15. And the adverse events was much lower in IVIG group. And one more study comparing IVIG and Plex in patients with myasthenic gravis. They have taken 54 patients of myasthenic crisis, and they found Plex is superior to IVIG. And one more study, comparative analysis therapeutic options used for myasthenic gravis. They have taken 1,606 patients. Among them, 698 patients were myasthenic crisis who were treated with plasma exchange. Who were treated plasma exchange have significantly higher mortality than those with IVIG, like 169 only. But this study has limitation that there are sicker patients they have done with Plex only. Coming to post-operative myasthenic crisis is more common after thymectomy, and the incidence is 12 to 34%. So what are the predictors for crisis of post-operative myasthenic crisis? Past history of myasthenic crisis, pre-operative bulbar weakness, pre-operative acetylcholine receptor antibody levels more than 100 nanomoles per liter, intraoperative blood loss more than 1 liter. So there is a study they have done to see the clinical predictive score for post-operative myasthenic crisis. It is a simple clinical predictive score, sir. Vital capacity less than 80%, 3 points were given. Duration of myasthenia gravis before thymectomy, if it is less than 3 months, it is 2 points were given. Bulbar symptoms immediately before surgery, 1 point were given. If the score is more than 3, there will be 25% risk of perioperative crisis. The last slide comparing the myasthenic crisis and cholinergic crisis, sir. Myasthenic crisis due to under medication, cholinergic crisis due to over medication. Myasthenic crisis, there will be increased heart rate, that is tachycardia, hypertension, tachypnea, bowel and bladder incontinence will be there. Decreased urine output, poor cough reflex, increased inability to handle secretions. So there will be need for mechanical ventilation, and this will improve with edrophonium or neostigmine. Cholinergic crisis is due to over medication of cholinesterase inhibitors. There will be abdominal cramps, nausea, vomiting, diarrhea, blurred vision, pallor, fasciculations, and hypotension and constriction of pupils. So they will worsen with edrophonium, but they improve with anticholinergic drugs. Thank you, sir. Thank you, sir.
It was a nice presentation. And Dr. Bala, I had a question for you. I mean, best for the PG students. Would you please elaborate the importance of follow-up levels of anticholine SHR antibody levels? What I mean by the question is, when you have a baseline SHR level, antibody level, and then when you treat the patient, how frequently you should follow up with the SHR antibody level, and is there any significance or importance of doing those levels, or it is not very useful as far as the prognosis or the follow-up of the case is concerned?
The antibody level, I think it is not useful for prognosis, sir.
So, in one word, it is not related with the severity of the disease. Okay?
Yes, sir. It is not related to severity of disease. Yes, sir.
That point you should highlight also. Wonderful. Dr.
Thank you,
Lakshmi,
sir.
there is one question in the chat box I find, and that is, what is the low-dose Plex regime, please, that is effective, evidence-based, and also low-dose IVIG for long-term in Indian guidelines? So,
Sir, normally, sir, there are it is highly the plasma, Plex, the volume which is removed is highly flexible, sir. We have been doing it for the past almost 5 years, and few centers they do 90 ml, sir, low volume, and we do sometimes in 60, 30, 60, and 90, sir. All the 3 categories we have. Normal patients, we go for normal patients with normal albumin and the normal coagulation profile. We go for 90 with replacement of occasional replacement, either FFP plus albumin or only FFP if the albumin levels are normal, or 60 ml per hour. Even the duration, instead of normal 5 hours, we can also do it as a 3 hours basis or 2 hours. It's all highly flexible. The slowly you can remove them, more and more antibodies you remove, the patient will show improvements. You can even prolong, not necessarily 14 days. We have patients whom we have stretched it over 20, 30 days also.
Yeah, Lakshmi, is there any evidence in favor of that? Are there any studies published, or are there any guidelines?
No, sir. We are, in fact, our GBS, we have a GBS registry, and we are collecting the data. We have done more than about 30 ml per hour, with more than 60 patients we have done, sir. We will be publishing it very soon, sir.
All right, great. So,
regarding this low volume plasmapheresis, I think it will work for GBS, sir. But as far as myasthenia is concerned, as much antibodies we remove.
The low volume for the GBS only. For myasthenia. In myasthenia also, there are few cases where they are planning for they wanted to reduce as the titer. When the patient is, most of the patients, our patients are not able to tolerate the high volume Plex. That's why most of them, they go in for hypotension, sir. That's what we feel. So we have preoperatively for preparing the patients for thymectomy, for the cardiothoracic department, we have done 60 ml also for 15, 20 days, 15, 10 to 15 sittings and reduce the titer and send it for surgery, sir. Not for the crisis. Not, sir, this is for preparatory phase for thymectomy.
Right, that's correct.
Yeah. In crisis, sir, in crisis when they are not able to tolerate, it is always better to straight away go for immunoglobulin, sir.
Yeah, that's what. And it's a very sad state of affairs that we have to discuss economics of immunoglobulin in our country. But I think our residents are smart enough and we also have a lot of resources. So I think a question of mobilizing resources for right patient like this should not be a problem. We have to somehow manage. And that's a sad state of affairs, I know. But I mean, there are people and there are people like Chadda also. So probably. So I think let's call it the end of the day today. And thank you very much for the wonderful discussion. And ice on cake was Dr. Bala's presentation. There were a lot of good questions. Dr. Lakshmi, you might want to put a closing.
My hearty thanks to Dr. Professor Shivakumar and its team. Excellent presentation, sir. And I am sure that this will be a very good review for all the postgraduates. Thank you, sir. Thank you so much.
Yeah,
And I hand over to Chadda for final.
Thank you, sir. It is our pleasure that you have invited us to present.
Dr.
Thank
Shivakumar, thanks to you and your team, Dr. Shivakumar, again. Thank you.
Thank you, sir.
Thank you very much, sir.
Thank you, sir. Thank you. Today it's really great as we are end of the 34th session of the Secret of Neurology. I, Arun Chadda, Assured Vice President on behalf of Intas Pharmaceutical, would like to propose a hearty vote of thanks to all the honorable delegates who blessed us with their presence in the last 34 months. It is audience like you that makes the presentation awesome. And I would like to thank our honorable course director, Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir for designing such a fantastic web series on neurology, which will be very helpful to all the DM and DNB students. And we are very thankful to young neurologist, Dr. Divya, for presenting the excellent and unique case. Further to this, I would like to thank Dr. Bala for case presentation and case discussion. And thanks to Professor Dr. Shivakumar, sir, Professor and Head of the Department of Neurology, Government Mohan Kumar Mangalam Medical College, Salem, for sharing his experience in this case and providing the important learning points for the proceeding of this unique case. The entire presentation will be extremely very helpful and informative to all the participants. Once again, thank you for your gracious presence. It's being with all of you today. Thank you for your patience, and we will meet again on 26th of May with yet another most awaited next session of Secret of Neurology. Till then, stay safe and take care. Thank you. Thank you to all of you. Thank you, sir.
Thank you, sir.
Thank you very much.
Thank you so much, sir.
It will be 26th May, right?
Yes, sir.
Yes, sir.
26. Okay, fine.